Here we go. And we're live. Welcome to JOFA's second webinar in our birth control series. We're calling it Birth Control Part 2. And the first webinar we hosted Rabbi Moshe Khan from Stern College for Women and the graduate program for advanced Talmud studies at Stern, where he talked about the importance of people having agency and autonomy in making decisions about family planning and birth control in their personal lives and not consulting a rabbi. If you'd like to see that, please click on the link below, which will be up there once this is posted on YouTube. But tonight we're here for part 2, and we're here with Rabba Dr. Carmella Abraham, who developed and co-taught the Women's Health and Taharat HaMishpacha curriculum at Yeshivat Maharat, utilizing her clinical medical experience. Carmella has interned at the Hillels of Westchester Columbia Presbyterian Hospital Chaplaincy Program and served as a fellow at the Shalom Hartman Created Equal Seminar Fellowship. She earned her BA from Barnard College and her medical degree from Mount Sinai School of Medicine. She practiced at the Women's Health Program, where she held a dual appointment in internal medicine and obstetrics and gynecology. She currently works in oncology and medical affairs for pharma. She's pretty impressive. We're also honored to have right next to her, you may see, Dr. Rebecca Amaru. Graduated from Columbia University with a BA concentration in anthropology, then received her medical degree from the Mount Sinai School of Medicine. She completed training in OBGYN also at Mount Sinai Hospital in New York City and has been in practice since 2003. She currently has a private practice with 2 partners on the Upper East Side of Manhattan and also is a member of the voluntary faculty at the Icahn School of Medicine at Mount Sinai, teaching medical students as a lecturer and preceptor. She lives in White Plains and is neighbors with Carmella. She lives with her husband, Dr. Jonathan Waitman, and her 4 daughters. Thrilled that you're here. This is an important topic that many people ask us about on a regular basis. A, for our medical advice, B, for the halakhic advice, and that's why we're so privileged to have the 2 of you here with your knowledge and the experience that you bring to the table. So I'm going to pass it on. Thank you for being here, and let's go.
Thank you. Thank you so much. So I'm just going to start, and then Rebecca, I'll hand it over to Rebecca. So today we're going to start from the premise that the decision to delay procreation has been made and a couple has decided to use birth control. To outline this evening, Dr. Rebecca Amaru will be doing a review of various birth control methods, after which I will comment about the pertinent halakhic issues that may arise. I would like to point out that tonight I will not be providing any halakhic psaks, but we'll discuss the issues related to the specific birth control discussed and strongly encourage those online to reach out to their personal post-sex halakhic decisors, whether it be rabbis, yoetzet, maharats, rabbi, or chachams, for individual questions and answers. If you prefer as well, I will be available later via email for private conversation. Maybe perhaps you can email Sharon with your questions. I will begin with a quick overview of the specific pertinent issues, and then Dr. Amaru will start with a review of each specific birth control type. Dr. Amaru has extensive experience taking care of women who keep the laws of family purity and has much to contribute tonight in reviewing what works best and how best to manage different issues that come up. Great example, and we're going to talk about it in a little bit, getting women to their wedding days, people who have gone to the gynecologist. Rebecca is the gynecologist, and people come to her after having failed and are still spotting and staining. So she really is an expert, and I look forward to
explain what we're talking about, chubat nida, what that is, in a sentence or two.
So for a kala, before she gets to her wedding day, must come out of the nida status and go to the mikvah, which will require her to do an internal check and hefsek tahara and do shevanakim, count 7 days before she goes to the mikvah. For her to be able to go to the mikvah, she cannot be bleeding, cannot have nida, and so typically those women are put on some sort of birth control, some sort of hormonal pill, and that usually happens a couple months before. Rebecca will talk about how best to do that. Oftentimes, women are bleeding and staining and really are biting their nails all the way till, they're just still bleeding before they can even get there. So that's really the concern. So once the decision has been made to delay pregnancy, and that can be for many reasons, and I know Rabbi Kahn covered off maybe in his shiur about that, and that is beyond the scope of today. The next question is, which is the preferable method? That answer involves a number of relevant halakhic principles. I'm going to just quickly cover off on them right now. So, of course, the issue of preventing peruvu, of being fruitful and multiplying. Again, as I said, Rabbi Kahn talked about that on his last shiur. The second, and probably just as relevant issue, is the emission of semen outside the vaginal canal, or destruction of the seed, of the male seed, called hotzat zera levatala, which is a halakhic prohibition. This is generally understood to be a biblical prohibition. The Shulchan Aruch talks about it in very serious language. That it's more serious than all the sins of the Torah. And there is a minority opinion that this is a rabbinic prohibition. And obviously they learn it from two sources, the story of Yehuda's sons, Ereb and Onan, and Tamar, that story, and the story of the times of Noach, when there is a reference to how the whole earth was corrupt and all flesh had corrupted its way on earth, and the Meforshim learned that they were practicing, the emission of seed levatala, right? So, that's an important concept that comes into play in terms of thinking about birth control, and therefore methods that allow for marital relations in the most normal manner, kederech kol haaretz, are the most preferable. Another halakhic issue is this idea of sirus, of sterilization or castration, and it's based on a pasuk from Vayikra, uma'uch v'katut v'natuk v'charut lo takrivu Hashem u'bartzachem lo ta'asu. I'm saying this very fast. Basically, the meaning of this pasuk is that we're not to bring a sacrifice or a korban of an animal whose genitalia has been damaged, and one is also prohibited from inflicting such damage. The Shulchan Aruch derives, and he paskins, that sterilization of men and animals are prohibited. By most opinions, this is a biblical prohibition for men and rabbinic prohibition for women. The prohibition of sterilization or castration is called sirus, and actually Rebecca is going to talk a little bit about that, really refers by most opinions to a permanent and stable castration, a condition, a permanent and stable sterilization, and not a temporary state. So, for example, vasectomies are typically done because even though you can reverse it, it's done for an irreversible purpose, as is tubal ligation. And so that would probably fall under, perhaps, most likely, under these categories, under that category. So just, again, to quickly outline the parameters, and I'm going to shift it over to Rebecca. The parameters are, we want to have birth control that does not impede semen in the vaginal canal and allows for marital relations in a normal manner, so we don't run into hotzat zera levatala. And we're always, and also thinking about the prohibition of sirus, we would like the birth control to be temporary and not a permanent sterilization. So with that, I'm going to hand it over to Rebecca.
So I like to divide everything into categories as much as I can. I think it's easier to think about it. And when I am talking to a patient about contraception, my categories come to the table, as well as whatever ideas that my patient has of either things that have not worked in the past, things that she has an inherent desire to avoid, and then in the case of a woman who is trying to bring halakha into the contraception question, certainly what she views or what her rabbi views as acceptable methods of halakha, of contraception, will come into that conversation. So the biggest division of categories of birth control is reversible versus permanent. And the permanent methods of contraception are divided into female and male. I do talk a lot about male sterilization with patients, really for a couple of reasons. One being that I like to shift the burden of contraception sometimes away from women after it's been their job for many years. And the other, that in many ways, at least surgical sterilization of men is simpler medically than it is of women. The exception is a woman who is having a C-section after completing childbearing, so having what she believes will be her last C-section. And in that case, sterilization is really very straightforward and easy to do at the time of cesarean. And so that is an option that I would offer. And more I talk about with patients the option of sterilization by removing her fallopian tubes instead of just ligating or tying her fallopian tubes. And the reason for that is that there is thought to be a decrease in the risk of ovarian cancer for that person. So in the Jewish community, for example, a person who is positive for the BRCA gene, which gives her a really, really high risk of ovarian cancer in her lifetime, at some point may be undergoing removal of her tubes for medical purposes in order to prevent the risk of ovarian cancer. And so at the time of cesarean, that actually might be something that she could do. And unlike the removal of her ovaries, which she might also opt to do to reduce cancer risk, this will not put her into an early menopause. So there might, even in a person who is following rules of halakha and avoiding sterilization, normally there might be justification for removal of the fallopian tubes for cancer prevention. But for the most part, in a person who is trying to follow halakha and use contraception, we take the permanent forms of sterilization kind of off the table. So then if you move towards the reversible world, I divide everything into methods that use hormones and methods that don't use hormones. And even in the methods that don't use hormones group, I'm going to throw in some things that hormones are kind of involved, but they're not quite the same as what I think of as hormonal methods, which are methods which are centrally changing the hormones in your body. So methods which are working on the axis of your brain and your ovaries in order to change things in a very global way. And the reason why that's important is that those are the methods that are more likely to have hormonal side effects versus methods that are locally using hormones, which are not changing your brain and not changing your ovaries and are less likely to have hormonal side effects. So in the world of hormonal contraception, the one that most people think of is the birth control pill. And even that is a little more complicated because you can divide birth control pills by different types. So I divide it a little differently. I divide hormonal into methods that use both estrogens and progestins and methods that only use progestins. So we'll start with the simpler one, which is the methods that use only progestins. The one that a lot of people have heard of is the mini pill, or some people call it a POP, which is a progestin-only pill. And the mini pill is not really mini, it's the same size as a regular pill, but it involves taking a daily pill form medication, and it works mostly by locally affecting factors that have to do with your uterus. So making your mucus in your cervix very thick, making the lining of your uterus very thin. It can occasionally prevent ovulation, but for the most part, it actually does not do that. And the great advantage of it is that it lacks estrogen. So for women who medically can't take estrogen, for example, a woman who has had breast cancer in the past, or a woman who has a blood clotting disorder where she is at high risk of blood clots and therefore estrogen is prohibited, or for a woman who's breastfeeding, and we know that estrogen can make your milk supply go a little bit lower, so avoiding it is ideal. This is a great option. The downside of the option is that it can cause some staining. So for a woman who really needs to have predictable bleeding, that can be problematic. And it can also have some side effects, although it's rare to see a lot of side effects with it. Some breast tenderness might be one possibility. Some bloating might be another. And really the biggest downside is that the effectiveness is not as high as it is with a combined pill that does contain estrogen. And that's mainly because it doesn't work as globally and doesn't prevent you from ovulating. So if you forget a pill and you don't take them every single day, your risk of pregnancy is substantially higher. In the breastfeeding woman, we like this method because the combination of breastfeeding and the mini pill actually often gets women up to a pretty acceptable level of contraception. The other methods that people use to take progestin-only contraception are injectable, so something called Depo-Provera, which is a once every 3 months shot. Highly, highly effective, but with a big downside for a lot of women, which is weight gain and irregular bleeding, particularly for women who are trying to avoid unplanned NIDA. The injection can really be problematic. A big advantage if you use it for a long time is that you may stop having menses altogether, which can be helpful. A big disadvantage with long-term use can be some bone loss, which can be a real problem for women who are at risk for osteoporosis. Another method, yeah.
Can I start with a question? So a number of people get nervous about missing their period for a long period of time, either because it just feels unnatural, or I've also been told that it can put you at higher risk for ovarian cancer or cervical cancer maybe. So
So certainly with progestin-only contraception, when you stop getting a period, there isn't an increased risk of ovarian cancer, and that's been studied pretty extensively. The first reason that you gave is actually something which is really challenging for women who are trying to prevent pregnancy and who are looking forward to the monthly kind of automatic pregnancy test of seeing a period. And generally what works is to show people the numbers. And when I show them how effective injectable progestin-only contraception is, more effective even than sterilization, believe it or not, if it's taken, on time every 3 months, then most women can be convinced that they really, really are not pregnant, even though they're having sex that feels unprotected because they're not getting a period. The other piece that comes in there is that I need to explain to women when you're not getting your period, why you're not getting your period. And when I do that, that works a little bit better at helping people to feel more comfortable with it. Because there obviously are medical reasons why women don't get a period that are really problematic. So for example, a woman who has very low body fat because of anorexia, I'm really concerned that she's not getting her period. Or a person who has polycystic ovary syndrome and is not getting her period because she's not ovulating, I have real concerns about that as well. And often I'm using medication to correct that. But when I really sit down and explain the rationale for why you don't get a period, in this case, you are actually doing all of the same cyclic things often, but your lining of your uterus is so thin that you stop shedding. Most women feel reassured by that. In the case of the injectable progestins, there is actually suppression of ovulation in a lot of women, which is why you can see bone loss and which is why it's problematic used long term. And really the main women who are using this method are women at high risk of making mistakes with other methods of contraception. So it's very popular, mostly among teens and among women who are not going to comply as well with other methods. Truthfully, the weight gain alone is a reason why a lot of women are not big fans of this method. So there aren't a huge number of women who are using it if they have other methods they can use. The Nexplanon, which is implantable, is similar to the shots, but instead of getting a shot every 3 months, it's actually a little rod that's implanted in the underside of your arm that releases on a very, very slow level progestin. It doesn't lead to as much weight gain, but it does have some irregular bleeding for months after placement in a lot of women. So again, for women who are hoping to avoid unnecessarily being in need of, this is not a method that's very popular. It also can be difficult to take out. So a lot of women are kind of anxious by what they've read about that. It's really ideal for someone who's not going to comply with other methods. So that takes care of all the progestin-only options when it comes to global hormone methods and not local. The other category is what most women think of when they say the pill, which is combined estrogen, progestin, contraceptives. And really, I'm lumping into that group things which are not really pills. So that includes things like the Nuvaring and the patch, which work basically the same as the pill, but are just giving you medication in different ways. One is it's soaking in through your skin, and the other is that it's soaking in through the walls. It can be administered vaginally. It just needs usually a little bit more time. In this case, it depends on the length of time of administration. So for example, a pill is taken every day. A Nuvaring is used for 3 weeks. A patch is used for a week. So it adds a level of convenience to administer it a different way. I also have found that with some women, the nausea that can be associated with birth control pills is reduced by avoiding the gut. So by using a vaginal administration, like with the ring, they will have fewer side effects. And that with women who are really sensitive to hormone mood side effects, that every now and then you'll see someone who tolerates a ring better because of the constant release of hormones instead of a pill where each day you have a small surge in hormones and then they fall slowly over the course of the day, and then the next day you experience a small surge in hormones. So, yeah.
One question in terms of having sex. Yeah. Are any, since we're talking about the use of hormones in a variety of ways, right. I guess one factor is that it could affect your wanting to have sex, but also are any methods more or less friendly for that?
So any estrogen containing combined contraceptive does have an effect on libido. Over long-term use, estrogen is going to raise a protein which binds to testosterone, which is your male hormones. Testosterone in women's bodies is a hormone that is really strongly associated with libido. It can be associated also with orgasmic function, but most commonly what women will complain of after years of being on combined oral contraceptives is that they do notice a decrease in libido. This is really hard to tease out because most of those women have also been in long-term relationships, which is also associated with a decline in libido. Many of them are having children, which is associated with a decline in libido. And many of them are aging, which is associated with a decline in libido. So it's challenging to tease out, but when you really compare head-to-head women on them and off of them in the same stage of life with the same kids and the same long relationships, then you see that there is actually a difference. And stopping the pill, that's reversible. So you will see a return of the libido that they remembered having to some extent.
Okay, thank you.
Okay, so in the combined world, there actually are 1 million products. And if you look in a pharmacy, you can see a ton of different products, and really they're not all that different from each other. The biggest differences are going to be in whether it's a monophasic pill, which means you take the same exact medication each day, or a biphasic or triphasic pill, which means that the doses of one or both of the hormones changes over the course of the month, and also in the dose. Almost every pill uses the same estrogen, which is called a phenyl estradiol. There's a little exception. The patch is a little bit different and the ring is a little bit different, but for the most part, you're really looking at the same estradiol. But it's a different dose, and it ranges all the way from about 15 micrograms, which is 1,000th of a milligram a day, all the way up to 50. Almost no one uses 50 microgram pills because the risk of blood clots is significantly higher with those. But on the commercial market, pills that are commonly used are going to range between 15 and 35. And believe it or not, 35 is actually not dramatically more serious or worrisome than 15, but side effects like headache or migraines and nausea can be dramatically different between a 15 and a 35. So I might have one woman who tolerates 35 no problem and another woman who doesn't. And the reason why I might use a higher dose in someone is that I can sometimes reduce breakthrough bleeding or staining with a higher dose of estrogen. And some women with a low dose, there is no way that they'll ever stop staining. And so that becomes really a problem for women who are trying to have predictable bleeding. The other way that they're dosed a little differently is that pills were originally marketed to try to replicate a natural cycle as much as possible, a natural cycle being an imaginary 28-day cycle. And they really don't have to be that way. They can be pretty much as long or as short as not as short, but as long as someone really wanted. So now more pills are being marketed with a 24-day of active pills and 4 days of placebo, or even 0 days of placebo. And some of them are even 3 months of continuous birth control pills with a short placebo period after that. The idea being that when you're on the birth control pill, your period is not really a period. It's not really the shedding of the lining of the uterus after a lack of pregnancy, which is what your period really is spontaneously, but rather it's the withdrawal of hormones. And so when you take away the hormones and you take placebo pills, you get a period, but that's not a natural cycle in the first place. So we've become less attached to trying to replicate nature and more attached to trying to give women what they're looking for convenience-wise, or for example, a woman with severe cramping with her periods, then medically we see a real advantage to suppressing her periods because she doesn't have to deal with taking as many pain medications and she has an easier time going to work when she doesn't have crampy periods. So we're seeing more and more very light, very short periods or no periods altogether with some of these combined hormonal contraceptions. And that requires also a little bit of counseling with women in order to get them comfortable with the notion that not having a period is in fact not risky for them. The big issue when it comes to NIDA is that whenever you do continuous dosing or use low dose pills, certainly in the beginning, you have a really high risk of unpredictable irregular bleeding. It's not a huge problem if that bleeding is very light staining that's not coming during a time when someone is checking, but it's a huge problem if right off the bat, right after they've had their period and they've started counting and they're ready to go to the mikvah and they need to look, all of a sudden they're experiencing staining, then that will really, really interfere with their lifestyle. And so we really kind of quickly switch methods if that's an issue, even though we know that with 3 or 4 months, they might settle down and stop being a problem. Most women are not going to tolerate 3 or 4 months of not being able to have sex because of their contraceptive method.
I just want to comment that also working with your, Etzet or your Maharat, they can actually help you determine if the stain is a stain versus a flow and apply the leniencies of stains that are available to perhaps, let's say this pill really works for you and it gets rid of, it feels good. You don't have side effects. You may not, have a problem with it. Perhaps if you could just work with work with your halakhic helpers and your doctor, you probably could get to a point where you could use this pill. So so that is also an option. And I just wanted to put that out there.
And most women are going to find that there's a varying level of comfort on the part of their physician with the issues that they're having. They may not even mention to the doctor that the reason that they're freaking out about their irregular bleeding is because they have not been able to get to the mikvah for 2 months. And I would really encourage people to say, you may not know about this, but I have this thing that I do, and it's really important for me not to have unpredictable bleeding. Because if you were not a woman who I knew was concerned about it, I would strongly encourage you to bear with it for 2 to 3 months, because I wouldn't know the extent of the difficulties that it was posing. And not everyone is going to be in the position that I am, where I can say, hey, there's probably a person who you could call to help you with this. Do you know of a yoetzet? Do you have a rabbi who is really helpful on this? Or can I help you find somebody who you'll be comfortable talking to? I think in huge swaths of our country, people will not know what you're talking about, but you do need to do a little bit of education of that doctor who doesn't know, and help them to know what the rules are that you need to be abiding by, so that they can be your advocate instead of throwing hurdles in your path, which it's easy for us to do if we don't know what it is exactly that you're hoping to accomplish. And that getting to the mikvah is as important to you as avoiding pregnancy. And so, part of our sex positivity needs to be realizing that there is a barrier, which I may not understand, but is really important to you.
Can I ask one question? Before getting married, how early would you suggest one starting to be on the pill to be safe?
So it depends on the person, because if I have a young woman who has incredibly predictable and regular periods, and we count things out and it's going to work out just fine, I'm not going to mess with her. I'm going to be hands off, and I'm going to leave nature to do its thing, unless she says to me, listen, I would like to be on birth control on my wedding night because I do not want to conceive after my wedding. Then there is no reason to start her on any hormones at all. And I think we do have this reflexive, you must be on the pill before your wedding. But if you look at women who have had a really regular cycle for the year leading up to their wedding, lightning is not going to strike for them on their wedding night. And you might do more harm with, 4 new zits on their wedding day that they really were sad about than you would have had if you had just left well enough alone. On the other hand, the vast majority of young women who come to me do not want to conceive immediately after their wedding. They want some time to get to know what being a sexually active person is like. They have professional reasons that they're not ready to conceive. They want to spend some time with their spouse, not making babies, but actually just being young marrieds. And we're obviously really sympathetic with that. Placing an IUD in a person who is virginal is incredibly challenging. So that is almost never the option that we're turning to. So it's almost always hormonal contraception. We'll get to IUDs in a second. For a woman who doesn't wish to be using hormonal contraception, she's used it in the past and it didn't work well for her, or she actually doesn't want contraception, but she's counted her cycles and it's going to not work out for her wedding night, or she has really irregular periods, so she has no idea what will be. There is actually a hormonal option of using a progestin only. We usually use something called agestin, which is a high-dose progestin. And just after ovulation, prior to their wedding, you start them on that medication, and it can forestall menstruation for essentially as long as you need. And often what we try to do is we just stop menstruation until they're a nida after the wedding, and then we try to overlap that wedding nida with the bleeding there, so that they're not going to be a nida twice in the month after their wedding. But again, the vast majority of women really are looking for cycle regulation and contraception before a wedding. I try to see them at least 3 months before. It gives me a lot of leeway to play. If I can have 6 months, that's even better. It allows all of the immediate side effects of a birth control pill to sort of settle down. You sometimes see what I think of as like surge side effects. So when you're first exposed to the hormones and your body hasn't had a chance to adjust the proteins that bond to hormones in your body, you can see an increase in bloating. You can see a change in the size of your breasts, which if you've been fitted very carefully into a wedding gown can really mess things up. You might see more acne, you might see changes in your hair, and all of those things after a month or two, the vast majority of times will settle down. More importantly is the fact that you'll see a lot of irregular bleeding in the first 2 months of being on a birth control pill. So if I have at least 3 months, I can say with certainty that I am going to be able to find a method that works for a wedding night. And if I have 6, I can say with absolute certainty. So I really encourage people to start early with me. It also just puts the unpredictability of things like acne at the wedding away. And beyond just getting to the mikvah before, we also are always trying to time the period after, because especially in a couple that is newly getting to know each other sexually, we really want to interfere with that as little as possible. So if I have the ability in someone who's interested in continuous contraception to have them stable on 12 weeks straight without a period, we do actually try to do that in young women who are getting married.
I just wanted to ask Dr. Amaru to just review with us. I have referred people to you who've been to other gynecologists, Kalas. What is the most common mistake that gynecologists make? And just so that everybody's aware of, when should I, push the button and do something else?
So a lot of it is not getting started early enough. So if I have time, I can adjust a few days a month on a cycle. And really pinpoint exactly to the date that women want to get a period before a wedding. So that's one problem. Another problem is that I think doctors panic because they are so worried about unpredictable bleeding that they give really high doses to people. And women don't tolerate that, and then they start to panic because they're having a lot of side effects and they don't want to feel bloated and fat and covered in acne at their wedding, and that matters to them too. I think also that, again, this comes down to making it clear what your objectives are. That if your doctor's not familiar with Taharat HaMishpacha, that they are very likely going to poo-poo your concerns and not understand how big of a deal the staining is to you, not change methods quickly enough if the time is short, and not kind of validate that this is actually really essential. So the main issues I've had have been those, and people sort of saying, well, you can't have everything. And I'm not really a believer in that. There are some women who really don't tolerate hormones. And so in that case, it is challenging to have everything. But you really do have to have a chance to try things out so we can really play with methods until we find the right one. So moving on a little bit, I'm summarizing the pills kind of quickly and not getting into a lot of details because they're really not that different from each other. And the reasons why we might change things primarily have to do with side effects and with irregular bleeding. And that, is fairly straightforward. And it just requires a little bit of tolerance and patience and understanding that we're winging it a little bit, that it's not predictable what the reaction that any individual woman's going to have. The women who really, really cannot use birth control pills are primarily women who get severe migraines from them or severe nausea from them. And then there are some women who have real mood disturbances from birth control pills. While lots of women will find that PMS or premenstrual dysphoric disorder is much better on the pill, some women will have real emotional lability from being on the pill, and they're not making it up. It's genuine. It might get better over time, but it might also really be untenable. And we need to be really sensitive to that, because if the only way that you're achieving contraception is by becoming moody and depressed and really sad, that's also totally unacceptable. So then we really have to entertain other ideas. And using short-term progestin before a wedding really does work. So, if all else fails, I can use that method, and then immediately after the wedding, I can usually get an IUD in. And if I need to place an IUD into a virginal woman, it can be done. It just requires usually some real great pain medication, some Valium, an excellent hand to hold, and it can be done. Okay. It's not so nice for them, but if you're really motivated, it actually is doable, and if everyone is really supportive of the desire to do it. So moving into the non-hormonal world, I split everything into barrier, intrauterine device, and other. So other is a big category. It includes things like spermicide and withdrawal and fertility awareness, rhythm, that whole group of sort of timing. And those methods are variable. Spermicide really doesn't have a very good track record. It's not really effective, and lots of women have reactions to spermicide with vaginal irritation. So you don't see a lot of people exclusively relying on spermicide. Withdrawal from a halakhic perspective, I'm not seeing a lot of women comfortable using that as a method. Believe it or not, it actually is not as ineffective as people think. No one likes to talk about it because teenagers are notoriously bad at withdrawal, so the public health world really focuses on that as an ineffective method, but it's not particularly different from condoms if done correctly, which is really the challenge. So we usually don't talk about that much, and in this context, it's not really a big one to talk about. Fertility awareness poses an interesting problem for women who are worried about Taharat HaMishpacha, which is that most methods presume that you will have intercourse when you have your period. Because if you take away the days of menstruation and the days following menstruation before you can go to the mikveh, and then you take away the days where you're fertile because you're trying to avoid getting pregnant, then you're left with very few days in the average menstrual cycle. So you end up with like 7 to 10 days, unless you are using an alternate method, like, for example, a condom or a diaphragm, which pose different problems, either in their level of effectiveness or in their halakhic challenges. So there are women who are following halakha in choosing methods who will choose fertility awareness, but they are sacrificing frequency of intercourse in a pretty serious way by choosing that method. So going to the other two categories, which are barrier and intrauterine device. Barriers comprises a few different methods. The condom, the female condom, which is basically the same thing, but instead of being placed on the man's penis, it's actually a ring on the outside of the woman's vagina, and then the latex condom that fits into the vagina. So it's worn by her, but it still acts as a barrier to semen in the vagina. So it poses the same problems from a halakhic perspective as the male condom. It's equally effective. Many women don't like them because it makes like a plastic noise when it moves. So unlike a condom, which is mostly silent, this actually has kind of like a saran wrap sound that people find a little disturbing. So it's not a hugely popular method. It's also really expensive. The diaphragm, the biggest issue with it is really effectiveness. It is not significantly more effective than spermicide used alone. And since diaphragms are used with spermicide, most experts think that really they don't do much, since the other part of the method is about as equally effective. Also can increase urinary tract infections, and lots of women mess up with diaphragms. The typical use versus the perfect use are vastly different. A lot of it has to do with a lack of spontaneity, where you have to stop in the middle of foreplay and place a diaphragm if you don't think about putting it in before. And then a diaphragm needs to be left in after intercourse for a significant amount of time to be effective, and sometimes women jump the gun a little bit too soon.
Also, when they remove it, can they cause some bleeding?
When
so
they scratch
themselves,
yes,
right?
But if you were properly educated about that bleeding, you would know that that would be vaginal or cervical bleeding, and from a NIDA perspective, should not be an issue at all. But I'm not a huge proponent of the diaphragm, only because I don't see it as effective as some of the other methods that are available to women. And generally speaking, if someone really wants a diaphragm, I would say to them, listen, I think you're going to need to be comfortable with the idea of an unplanned pregnancy if this is our choice, because the rate of pregnancy is substantially higher than it would be with other methods that are available to you. And that's okay. I think some women are less unhappy about the notion of unplanned pregnancy than others, and so that choice might be the right choice for them at that time.
Quick question. Halachically, what's the difference between a female condom and a diaphragm? Or just, yeah.
So that's a really great question, because the diaphragm is very interesting in terms of being a barrier method. And there are some that will allow it because it is inserted more deeply. And so that it may be more permissible, and some rabbis will allow it in the cervical cap. They'll be more lenient about it. Some authorities actually permit these methods actually over contraceptive methods, or if there's an issue with contraceptive methods that they cannot get it, they will prefer barrier methods such as the diaphragm or the cervical cap. So the female condom is very interesting because it, in some ways, it does allow for, sort of, in the normal derech of sex, but it really does catch the semen. And so in some ways, it's perhaps a different kind of condom, I would imagine. So, so I think that
for whatever reason, it sounds like the diaphragm is not actually considered a barrier, which kind of makes sense based on what you've shared with us, and that it's really the spermicide. Is that?
Well, the diaphragm is meant to be a barrier between the cervix and the uterus. So sperm is in the vaginal canal, and so that's why some rabbis don't find it objectionable. And if the diaphragm is properly sitting across the cervix, then it is thought that that would prevent the sperm from them entering the cervix and getting into the uterus. It isn't that effective, largely because in a lot of women, it doesn't sit correctly on the cervix. Female anatomy is hugely variable, not just across women, but in women across their own reproductive lives. So before children, after your first, after your second, as your body changes and maybe there is more prolapse of the vaginal tissues, then the fit of the diaphragm can change with all of that. And so some of this may be that no matter how often you get your diaphragm fitted, it just isn't really correctly fitted. But there's no question that sperm is in the vagina. Similarly, with a female condom, you could make the argument that sperm is in the vagina, that it simply is not getting past that barrier into the cervix. So depending on how you define barrier,
right. Exactly,
you could make a different argument there.
The diaphragm is also deeper within the vagina, and that's really the issue, that it doesn't really affect sex, right? It doesn't really get in the way, and so that's really why it's perhaps different.
So two quick things. I don't want to get sidetracked, but I do want to. One thing is, as an ardent student of Dr. Marcus with our podcast, The Joy of Text, intercourse is a type of sex, but not all sex. So I just have to throw that out there as
thank you.
Of teachings about sex. And the other question that I had is, I'm a college teacher who's been trained by the Yeshiva Chovevei Torah, Yeshiva Maharat, Jofa, Chatan Kala teacher training program. And I've had people ask questions about having sex with intercourse with the Nuvaring, and that sort of being in the way. So if you could address that before we continue with IUDs.
So the vast majority of women do not find that the Nuvaring interferes with sex. Every now and then you have a partner who feels it, who finds it uncomfortable. There is no problem at all with removing the Nuvaring during sex. So it is normally sitting in the vagina for 24 hours a day, 7 days a week, except for the week that it's removed. But there is some leeway, and certainly removing it during intercourse, taking it out, setting it on the side of the sink, putting it back in when intercourse is over. It's just important not to forget. So I always say the side of the sink because I want people to see it when they go to brush their teeth before they go to sleep or whatever it is they're doing. And you can put it right back in. So there is some forgiveness to the method.
And that's also permissible when you go to mikvah as well, right? And you can leave it out for up to 3 hours. Is that correct? Mm-hmm. And then you just have to remember to put it back. That's
right.
Really good to know. Okay.
Nuvaring also has a lot of forgiveness. No, it's not advertised with the method, but each ring actually has more than 3 weeks of hormone. Each ring actually has 4 weeks of hormone. So for women who are looking to do back-to-back cycles, who are looking to avoid going to the mikvah, who have tried before and have found that they can do more than 4 weeks of continuous contraception and they don't bleed through, that woman can use the same ring and then replace another ring immediately after 4 weeks. The reason why this is a huge advantage is that if you have a pill pack and it has 21 days worth of pills in it, and then you use a new pill pack with another 21 days of pills, your insurance is eventually going to catch up with you and tell you that you're not due for another pack of pills. With the Nuvaring, because you can actually work 4 weeks out of each one, you don't get dinged by your insurance company, and so it can be a real cost saver. So I have found that with women who do really well with the ring, who are trying to do continuous cycles, I use the Nuvaring a lot. So the cervical cap, I have never even seen one with my own 2 eyes. Their effectiveness is actually even a little lower than the diaphragm, and I'm not even sure if they're available on the market. But they're in every contraception lecture, so we'll throw it out there. But it is a barrier that sits right on top of the cervix. Really, really, really not commonly used. So then that brings us to the IUD, which I would have to say is right now the hottest object on the contraception market. There's been a huge push in the public health world towards what we call long-acting reversible contraceptives, or LARCs, because they are so incredibly effective. Studies have shown them to be more effective even than sterilization, and because they're reversible, and because they're really quite cost-effective, even though there is a large upfront cost with them, particularly since a lot of insurance companies right now are covering contraceptives. They can be a great cost savings for a woman who's paying $80 a month for a birth control pill. She might actually spend a lot less money on the intrauterine device. I think that the biggest advantage to them is that they are kind of worry-free. You really don't need to do anything beyond getting an IUD placed. And that has a huge advantage, particularly for women who are working and raising children, and contraception just really can't occupy the forefront of their brain. So we find that there's 2 categories of women where I really put a lot of IUDs. One is the young woman, which is not falling too big in the JOFA context, but the young woman who is sexually active and pregnancy is really absolutely unacceptable to her. Hormone side effects are sort of not PC, and so this is what she's choosing. But in the other category is the post-pregnancy women. So women post-pregnancy are the most certain women in the world about when they wish to have another baby, particularly in the immediate postpartum period. Many of them, I would say, are virtually in a panic about the thought of having a pregnancy prior to the time that they are ready. And they feel really incapable sometimes of remembering birth control pills or rings or any method that requires that they do something regularly. So the intrauterine device is just an incredible advantage in that setting. So those are divided into two categories. And I'm including this in my non-hormonal category, even though one of them is hormonal, because the hormone that's secreted by the intrauterine device is in such a low dose and in such a local fashion that the vast majority of women will never experience any system-wide or systemic side effects from these IUDs. There are exceptions, and I talk about them with women. The most common thing, actually, that I hear women complain of is a little increase in acne, and that is a systemic side effect. But the vast majority are not experiencing the kinds of mood alterations, changes in headaches and nausea, things like that, that are real game changers with birth control pills. So let's start with the non-hormonal IUD. There's really only one main one on the market in the United States. It's called the Paragard IUD. It is basically a small T-shaped device that sits inside of the uterus with the two arms of the T going toward the fallopian tubes and the base of the T going toward the cervix. There's a small string that sticks out of the uterus and goes to the outside of the cervix, to the very top of the vagina.
Should I attempt this?
We're gonna try and show you a picture of what an IUD sitting in the uterus looks like. And there's a little copper wire that is around the central line of the T. So here, we'll see if we can pull it up.
Yep.
Okay, can you see that?
Yeah.
Okay, terrific. So this is actually a picture of a Mirena, not a picture of a Paragard, but if you imagine that central white core of the Mirena instead being a copper wire, that's what it would look like. A lot of women think that this is like a tampon where there's a string sticking out of the vagina, and that's not actually true. The string is coming out of the cervix. You can reach your finger up to the top of the vagina and feel this string, and we actually encourage women to do so, but you will not have anything that could interfere with intercourse. You don't have anything that will actually come out, into your underwear, and the string itself is really not an issue at all. We can go back from there. The IUD is basically the most effective reversible method of contraception that's out there.
Did we come back?
We're just trying to get the camera. There we go.
There we go.
The copper IUD has the main disadvantage of the copper IUD is an increase in menstrual flow and an increase in menstrual cramping, and often in a small increase in the length of menses. So you can imagine that that might be a real issue for someone who is carefully counting days before mikvah. So I ask a lot of questions about your baseline period before I put in a Paragard IUD. So if someone says to me, I have an inconsequential 3 to 4 day period with cramps that never require any ibuprofen, never interfere with my life, that's a great candidate for the Paragard IUD. If someone says to me, my period lasts for 7 days, my whole cycle is only 25 days, and I have some cramps, I take ibuprofen every single month, that is not a great candidate for the Paragard IUD. The good news is they can be pulled out. If it doesn't work and you're unhappy with it, then it's reversible. That's exactly the point of reversibility. The other advantage from a mikvah perspective is that when you place the IUD, you may have a little bleeding that very day, and we usually do it right at the end of a period. But then you're done. Then you're going to menstruate on your regular cycle. You're not going to have mid-cycle bleeding typically, and so you will have predictable bleeding just as you did before. So it should, other than that first insertion, which we typically do when you have a period, so again, it's already overlapping with NIDA that exists. It might lengthen the time of NIDA that first month, but that's it. And then beyond that, there should really, other than lengthening your period each month, not be an interference with your cycle.
So I just wanted to ask Rebecca about how much you dilate up the cervix to place the IUD. And the bleeding, it's typically you ask patients to come in when they're having their menses.
So usually the last day of menses or a day after, a day or two after, which works really well from the perspective of Taharat HaMishpacha, because you're not going to increase the length of bleeding by too much with that. The dilation of the cervix to place the IUD is minimal. The width of the inserter, which I use for the applicator, is a couple of millimeters. And there can be bleeding from a couple of different places when you place the IUD. We usually grasp the cervix with an instrument while we place the IUD. So you can have bleeding from that. And I am, because I can say to a person, because I know what their concerns are, I will tell them, The only bleeding that I am seeing here is bleeding from your cervix. And again, this is where you might have to be part of the process with your gynecologist and say, if my bleeding is from my cervix, that's not a problem. But if you see blood coming out from the cervical opening, that is a problem. Then they will be able to tell you, and hopefully they will not poo-poo your concerns. Hopefully they won't be dishonest with you.
Right.
But you can get them to be your advocate there.
And we can assume it's called dam maka, right? It's from a wound, and then that should be absolutely permissible. But of course, doing it around the menses or after you go to mikvah, between the time for mikvah to your menses are probably the best times versus your 7 count. Yes.
I know this has come up because a lot of people in the Orthodox world, I think, tend to have an IUD inserted after having a child, and then they're not necessarily having their period. So I think that's important to take into account, that if you're going to be doing BD code and wanting to go to the mikvah, it's a bad, don't time the IUD before that, basically.
Right. So you can, I often actually delay IUDs for a few weeks after that initial 6-week postpartum check. A lot of women are ready to have intercourse, but I do think that there are some advantages to giving them a little bit longer before I place the IUD. But evidence shows you can place an IUD immediately at the 6-week visit or even before. But if they've had a chance to go to the mikvah already, then the bleeding that they experience from an IUD insertion is not bleeding that should put them back into nida. So as long as they know to tell you what you're supposed to tell them, that can be really helpful. But they, again, most physicians who don't take care of women who are interested in these rules are not going to know. And if you say to them, is there any bleeding? Or if they say to you, is there any bleeding? They're going to say yes, because there is going to be some bleeding. But if I am clear that the bleeding is exclusively from the cervix or a small amount just from touching the walls of the uterus, and that bleeding, if they're guided correctly by whoever is counseling them, is really not bleeding that will constitute a flow, then they really should be okay. So move now to the hormonal IUDs. There are a bunch of brands out there. There's a lot of competition in this market because it's a really rapidly growing area. The one that was the first one on the market in the US is called Mirena. But basically, they all use a hormone called levonorgestrel, which is a progestin. And there is a little core of plastic in that central line of the T of the IUD. And that core releases over a period of 3 years or 5 years, depending on the IUD. Incidentally, the Paragard, the copper, is a 10-year IUD. So over 3 years or 5 years, it releases varying amounts of levonorgestrel. The newer products that are coming out now are all tending toward slightly smaller devices, which are hopefully a little easier to place, and lower doses in order to try to limit any hormone side effects. Much of this is the battling between pharmaceutical companies for market share and not substantial differences between products, but the copper IUD went on the war path against the hormonal IUD about hormone side effects. So now the hormonal IUDs are bringing out lower dose products, which is wonderful for women. So this fight is actually really great.
Yeah,
exactly. So the newest IUDs that are out there are a little bit smaller and a little bit lower dose, which is advantageous in some ways and disadvantageous in others. And here's why. The higher dose 5-year IUD has a very high rate of what we call amenorrhea, which means absence of menses by the end of the first 12 months of use. There is a downside to this upside. The downside is that they have a high rate of bleeding after insertion. So when you first place the IUD, I counsel women to expect between 2 and 8 weeks of irregular bleeding, which you could imagine if you are trying to figure out how to get to the mikvah could be a real problem. And it is a real problem. On the other hand, if what you can look forward to is after somewhere between 6 and 12 months, 5 years of no menstruation at all in a very healthy and safe way, that has real advantages to a person who would rather not go to the mikvah monthly. The reason why they're developing lower dose products is partly to avoid side effects, but partly something which you alluded to before, which is that some women are not comfortable getting no period. And so particularly products that are being marketed toward younger women, we're finding that they really like to see menstruation every month, and that they're not happy losing their periods. The woman who has given birth and is managing her children and the rest of her life, that is the woman who is thrilled not to get her period. So the slightly higher dose IUD, which has a higher rate of amenorrhea at the end of that first year, is generally more popular with her. So I'm thinking that we're going to see the Mirena eventually phased out, and the lower dose 5-year IUD is probably going to take over. But I'm not sure that's going to make a lot of women in the more observant community happy, because they're really thrilled with the side effect of no period.
I do think it's worth throwing out. It's so popular that a number of communities have asked me why people are not using the mikvah as much anymore, like why people are not observing the laws of Eretz Mishpacha, and I said they're just finding a way out, and it's the IUD.
It's not 100%. It's about a 25% rate. I'll tell you, anecdotally, my experience is that it's higher than 25%, but by the book, it's 25%. And I think the reason why they're only saying 25% is they're not counting. They're counting true amenorrhea, meaning no menstrual bleeding whatsoever. And there are a lot of women who do have an unpredictable stain or spot here or there, but that blood doesn't actually count from a Taharat HaMishpacha standpoint. So from the mikvah perspective, they're still able to not go to the mikvah. They do need a good amount of counseling, though. They need counseling to get them through that first couple of months. You need to have your eyes wide open, particularly if you place an IUD in a time where it's just really important in your marriage that you be able to have intercourse. And so sometimes after childbirth is actually a pretty great time, because a lot of women are not so excited to be having lots of intercourse. And so having, I mean, this sounds kind of awful, but having an excuse not to be having a lot of sex can be helpful for a new mother who really would rather go to sleep. And so I'll talk about that with them. But if instead it's someone who is finding that in the postpartum period what they really, really need is intimacy with their husband, and the way that they do that is through intercourse, then placing Mirena might not be the right choice, because I will really interfere with something that they need to be doing at that time. So that needs to be a pretty honest conversation. And I call it an investment. I think you need to be willing to invest in the short term for something that will long term pay off, but the short term investment is hardcore. And you need to know that you may not luck out. You may not get high. You may not get the full.
It's like a video, you know, where my kids are coming in.
Oh, I can't.
Sorry, go ahead.
Okay, so that really covers the IUDs. The biggest issue really with those is preparation. Preparation for the fact that the insertion is somewhat uncomfortable. After childbirth is a great time to place them, because they tend to be less uncomfortable then. There is a risk of them coming out, but that risk is really quite low. And there are some complications. And for women who do a lot of internet research, you can read some scary stories about really any method of birth control, but IUDs have some particularly dramatic ones. So it's really important to ask a lot of questions and be reassured. And with respect to not having a period, to allow us to give you a real explanation for why it is not dangerous for you not to have a period.
Can I ask you a question, which is a little bit off the chart? Do you ever have male partners come in to have these conversations, or do you encourage women to talk to their partner about it?
So we often are talking to either pregnant or recently postpartum women about birth control. And so those women often have a man there. But I would say the vast majority of these conversations happen without a partner. I have a bit of a reputation for advocating hard for the male contribution to the contraception conversation and to the contraception choice. Sadly, there just aren't a lot of options out there for male contraception. So beyond condoms and sterilization, like that's pretty much the end of the show right there. So if you're talking about in a halakhic context, then we've just knocked off the two methods which allow the male partner to be in there. Here's where it becomes really relevant, though. Couple that's been married for some time, and child rearing and work and the sort of grind of married life are in the way, and libido becomes a real issue. So that fight about frequency of intercourse, which is really common as marriages go on, can come up and be a real issue. That sometimes is really hard to tease out because people are so embarrassed to talk about fighting about sex, even though people fight about sex in virtually every relationship. And so once you hear that, then really the onus is on us to offer ideas about what to do. And that might require a partner being involved in the conversation. But I think they're kind of in the background of that conversation a lot of the time.
Great. I think we're done.
You've gone through quite a bit.
Okay. You reviewed quite a bit.
To spare.
I guess it might be worth asking, what are your top 3 most common questions asked from observant community that the answers might be helpful to those who may be. And I think one thing that we've learned quite a bit about is that communication is really key. So whether or not you have a doctor who is well-versed in halakha and the ramifications, that communication is important. But even with that, what are some questions that are asked so often that it would be good for people to know without having to ask them?
So I think we answered the kala question. I think that often gets asked about how do we get there. I also think this the chronic bleeding and staining on birth control pills. I think, the bleeding that happens on IUDs, perhaps after postpartum bleeding, is it a stain? Is it a flow? How do I determine which is which? To calm people down, to try to get to the leniencies of the stains and the kulot, and think of it that way. I think asking about going to mikvah, I think the Nuvaring question about, well, can I take it out? Is it a chatzitza? What do I have to do about it? It was interesting, we read all about the patch, and it turns out that the patch is very uncommon, which is what Rebecca was telling me. But when I was reviewing and seeing some of the questions that have been asked, apparently the patch, you can take it off before you go into mikvah, but can you put it back on? Will it stick back on? And, can you get another one? But then apparently it's not so common.
It's not as commonly used. The dose
in the United
is
States,
a little higher.
Perhaps, or in
yeah,
Israel,
there were 2 main issues. One was that everybody hates the adhesive. It leaves like little rings of adhesive on your skin, so they don't like that. And the other is that there have been some studies that show that your ultimate dose of hormone is actually higher with the patch than with the pill. And so it got a lot of bad press as a result of that. I think also that the Nuvaring added such a big advantage because it wasn't weekly, that it just kind of outstripped the patch very quickly in terms of what women were looking for. Doing something once a week just wasn't such a great advantage to them compared to doing something once a month. I think that really covers the majority of questions. The other thing that's really important to keep in mind is that establishing a new contraceptive method is much different from a NIDA perspective than being on an existing method. Because if you know, either through working with whoever your counselor is or through a doctor that knows a little bit about this, if you know that some of this bleeding doesn't need to be witnessed and it doesn't need to be counted, on an established method, that's really helpful. If you are just starting a birth control method, then often you're doing it in the context of a period. And so that can make it really essential that you are looking at what's coming. And so that starting up period, again, it's sort of like with the IUD, that there's this investment of getting to a method that works for you and knowing that no one is expecting you to go months and months without being able to have intercourse, but that we really do need sometimes to play around till we get to a method that works for you from a Taharat Mishpacha standpoint and from a contraception standpoint.
Great. Thank you.
Thank you so much for cramming in a wealth of information in a very short period of time. I think that I've learned a lot, and I'd imagine that all those viewing and who will be viewing in the future, that if you're watching this and want your OBGYN to see it, or anyone in your community, it is now a resource that will always be available online. So please take advantage of that. Also take advantage of our website, of our Facebook, of everything, jofa.org. And thank you again to our 2 experts who shared quite a bit of important, relevant, expert information tonight. Thank you so much for making the time.
Thanks.
Thank you, Sharon. Thank you so much.